a bit of a background to today's presentation and webinar was clearly we're all working in very exceptional circumstances at the moment, and as a result of the response to COVID, we've been meeting more frequently with our local authority LIMF representatives, so local implementer national forum representatives, to have a conversation about the challenges around stopping the NHS Health Check programme and some of the issues and considerations that have occurred during this period where clearly the system has needed and everyone has very much needed to respond to the emergency of COVID-19. And it's through those conversations we've identified a series of questions and issues, and we felt it'd be helpful to really bring those into a bit of a framework, and subsequently we've published that framework as a restart preparation document. And the intention is that this document is there to signpost and guide you to other existing sources of advice during this very transitionary period that we're in at the moment, this very unusual period we're in terms of trying to think about how we operate services or how we plan, in particular the health checks, to restart operations whilst we're also still managing and dealing with the situation that's presented to us as a result of COVID. So the guidance that's out, and Alicia did send a link to the website so you can access that guidance. And as I say, it's very much about signposting to existing sources of information rather than creating anything new. And it's very much for this transitionary period that we are in now, and clearly things are moving very quickly and they're still changing on a day-to-day basis. So we're going to continue to keep that document as a live document, and as new information and guidance comes to light, we will update it and notify you. And so the intention is really to try and take some of the work out of the system, so it gives you a one-stop shop really, where you can then find other sources of information that will help you in your day-to-day work. Okay, Alicia, can we move on to the next slide, please? So the best place to start really is, why start the NHS Health Check? So I think the main message for me is really important that we do get the NHS Health Check programme restarted. The government has already signalled its longer term commitment to the programme continuing. So the recovery strategy for COVID-19 mentions the NHS Health Check and the role that it has to play in helping to deliver preventative and personalised services. So much of what it seeks to achieve in terms of its own original objectives very much are transferable to this situation. So obviously we're looking to reduce risk in the population by tackling those risk factors which we know are driving the burden of non-communicable disease. And some of those risk factors, it seems, as the evidence is emerging, are also associated with COVID-19, which presents a unique opportunity, but also some challenges as well when we think about how best to get that programme restarted. Okay, so moving on to the next slide, Alicia. So the range of questions that have come up with our local commissioners through the Local Implementer National Forum fit broadly into 8 categories, and that's how we've broken up the guide. And I'm just going to run through each of these sections really quickly in terms of the key messages that we've got in the document. So if you can move on to the next slide, please, Alicia. So for those of you who don't have the slides in front of you, we're on the slide that says when to restart. So the decision on when to restart the NHS Health Check is a local one to be made in consideration of other guidance that's out there. And there are 2 key pieces of guidance. First is the letter that came from NHS England out to community providers advising that the health check should stop. And that expires on the 31st of July, which is the end of, and obviously clearly the end of this month. The other piece of guidance that's important to consider is that which has been published by BMA and RCGP, which was about aiming to restart services now. So that's recently changed. They've reduced the level to a level 3, and they're suggesting that those services which were previously listed as red, that practices should aim to restart now. But very much this is a local decision. And obviously now we're seeing with COVID, it's affecting areas in different ways. We're seeing different levels, and some areas are having to still lock down. And so it's not going to be appropriate for those areas to really even start thinking about restarting. But for those areas, in terms of think about your local context and kind of how COVID has emerged in your area and your risk status overall, and thinking about this guidance in relation to your local context will be really important in then informing a local decision about the appropriateness of when to actually restart the programme. Next slide, please, Lisa. So just to also recognise that the programme continues to be underpinned by local authority regulations, and these set out the requirements that make up the NHS health check, and that it must be offered to eligible people every 5 years. And in many ways that's really helpful because it offers flexibility to accommodate the temporary suspension that we have at the moment, but also it really highlights the need to think about how we're going to continue to deliver the service going forwards, and that we do need to meet these objectives over a 5-year period. But at the moment it offers a really helpful flexibility in terms of that 5-year cycle rather than it being an annual cycle. Next slide, please. We've also had a number of questions around funder and provider payment. They've very much been focused around activity and payment whilst the programme has been suspended rather than when the programme has restarted. And there is clear guidance here for commissioners called the Policy Procurement Note, which comes from Cabinet Office. And there's also accompanying frequently asked questions that go with that. And again, it's not a one-size-fits-all approach. It very much comes down to who your local provider is, how they're set up, whether they're likely to go through hardship as a result of funding being stopped. So again, this is something that each local area needs to consider in relation to their own context to make an appropriate decision around funding and payment whilst the service stopped. As and when the service resumes, again, it will be looking really to think about moving back to original contracts and contract provision and payments that had been set out previously. So again, so it's thinking about what were the previous requirements and are they still fit for purpose as we move into a transitionary stage in terms of recovering and restarting the service. We know there are lots of pressures, cost pressures arising from COVID, and this situation continues to evolve where the government has announced funding which is non-ring fence for councils. So again, it's thinking about how, if at all, that resourcing might be able to support any future access or action around the NHS Health Check programme. Okay, next slide. Now, clearly, staff and patient safety is of the utmost importance. So, again, in terms of thinking about restarting and preparing, it's really important to consider what the risk will be to reduce that risk to the workforce and in the workplace, and also patient risk. And many of you will be familiar with this, I'm sure. So it's not necessarily about doing anything new, but it may be about enhancing existing risk assessments. And it may well be about, again, thinking about other ways of minimising risk. So clearly virtual appointments, appointments over the telephone, other ways, alternative ways of delivering the NHS health check in order to minimise risk are important considerations, and certainly will be things to explore, that the commissioners and providers together will need to explore how that might best work on the ground. Clearly the guidance from the NHS is to avoid contact where that is deemed unnecessary, so obviously face-to-face contact only where it's absolutely essential, and therefore we need to think about alternative delivery models and how we use and put to good use many of the changes that in particular primary care has already implemented in gearing itself up and being able to respond and deliver important healthcare services whilst also reacting and responding to COVID-19. Next slide, please. The other major theme was around workforce capacity. And again, the challenges of particularly being able to respond to any outbreaks of COVID-19, also commissioners potentially being redeployed to work on other areas. So thinking about both commissioning and provider capacity in relation to restarting the service. And again, I think this is where alternative delivery models might have a role to play, and again is something that should be discussed between provider and commissioner, given that we have a fixed capacity within our existing system. And this could be a really great opportunity to think about how we might provide the service at a higher geography, or to other alternative methods of delivering the service in a way that makes it accessible, enables capacity to be maintained, but again without overwhelming practice or primary care. Next slide, please. Another theme that came through in the conversations is very much about workforce competence and confidence. Clearly there's been a number of months have lapsed since colleagues have been delivering NHS health checks, and it's really important as we get back into the swing of the service that people do have the right skills to be able to deliver the check itself, but also to work in new ways. So having that opportunity to really deliver the check through alternative means, but being able to have the competency and confidence to do that. So if that's using a virtual platform, ensuring that those staff have had the right training and support to be able to actually use and deploy that platform. And still coming back to our competency framework, that very much remains at the heart of a high quality check. So we're still very much looking for anybody who is delivering the check to ensure that they are meeting those requirements set out in the competency framework, but also then that they're getting the support and training that they need to deliver the check in alternative ways. Next slide. So a further consideration for commissioners that was raised was really the availability of follow-up services. It's really important for the health check to maximise its impact, and for it to be able to do that, we need to ensure that there are both lifestyle services and clinical management interventions available to ensure that those individuals who are identified with high blood pressure or at high risk of cardiovascular disease, for example, get the right clinical treatment that they need, but also those people who are identified as being overweight or having non-diabetic hypoglycemia, for example, are able to get the behavioural interventions that they need as well. So it's really important that we maximise the value of the NHS health check, and that means having the right follow-up services in place and actually operating. So again, thinking about whether those are operating in your area and the extent to which they're operating is really important in helping to inform your decision about when you restart and how you restart the service. Next slide. And finally, but very importantly, equity was a key point raised by local commissioners, and clearly we've also had the findings from the review of disparities in relation to COVID-19. With the implementation of the NHS Health Check programme, we've always adopted the ethos of proportionate universalism, and therefore we would look for you to ensure that there's an unequal distribution of investment and resourcing and time to ensure those at greatest risk are actually getting the check earlier than those who are least likely to be at greatest risk. And I know many areas have been able to do that and have been implementing that approach, and we're seeing some really fantastic results coming from that. So very much that principle of proportionate universalism very much still stands and becomes even more important. I think that the challenge here is reconciling that those individuals who are likely to have the most to gain from an NHS health check are also probably more likely to then experience COVID as well. So thinking again about the risk in terms of setting where the check's being delivered and the workforce delivering the setting is really important to minimise risk in relation to COVID-19. We very much will be looking to colleagues to try and use resources like our health equity audit tool and that associated guidance to really inform thinking about how best to approach implementation locally to ensure those that have got the most to gain are prioritised and do get access within a safe environment to have their NHS health check. Okay, next slide, please. So that's a very brief roundup of the information that's in the document, as I say, that we published last week. Just to reiterate, the document is intended as a signposting document. It's not got any new information in there. It's really about bringing it all together under one umbrella. It will remain a live document, and we will continue to update it regularly and to let you know. We'd really very much welcome your feedback on that, and we'll come into that in the discussion. What I'm going to do now is I'm going to hand over to Paul and then to Linda, and they're going to reflect on their thinking and experiences in starting to work through how they might be their preparations for restarting the NHS Health Check programme.
Okay. Hello everyone, my name is Paul Stokes. I'm the Head of Programmes for Health Improvement in the Public Health team at the London Borough of Southwark. I'm also the London representative for the Local Implementer National Forum, the LIMF group for NHS health checks nationally. And Catherine's asked me to talk today through some of the experiences the last couple of months of trying to stand back up the programme after it was paused back in middle of March. So I'll talk through some of the areas of the restart paper. So the first area is what steps are you planning to take in preparing to restart the NHS Health Check programme? So in Southwark, we have worked with our two GP federations who deliver the programme with us. We commissioned them and they deliver through GPs and also through pharmacists. We're looking at a phased approach to restarting, including some time-limited interim solutions to deliver an alternate NHS Health Check programme in Southwark. So the first phase we're looking at with partners is implemented in July and potentially August, is using telephone consultations or e-consultations with patients that have an existing relevant and recent blood pressure and cholesterol on their medical record. I know from speaking to colleagues in South London that other boroughs are looking at this as a first start solution. So boroughs such as Lewisham and Sutton are also looking at this potential solution. So in Southwark, we looked at the data on the GP record and found that about 700 eligible patients had both a BP and a cholesterol on their record but hadn't had an health check. So That's within 6 months the date of the checks, and then if you go up to a 12-month date, then it kind of goes up to 2,300. So there's quite a good low-hanging fruit there for GPs to contact. So what that would be just contacting those people, completing the rest of the check over the telephone or e-consultation, and then generating the cardiovascular risk score and diabetes risk score, and potentially what services they go on to thereafter. So that's a kind of a first stage approach. The second stage approach, phase 2, would be utilising our digital health check tool that we've got in Southwark. Has been running since July 2019 as a chaser for those people who we've invited to an NHS health check who haven't turned up. So the idea there is to send out invitations to complete the digital tool and use that as an engagement for them to complete, and then higher risk people will be referred back to their GPs for a follow-up consultation over the phone, or potentially to pharmacies. And those with lower risks or minimal risk would be diverted over to health interventions. Mostly of those are delivered digitally at the moment, but they're still running, and we want those services to be maximised. And then working towards a phase 3 approach, which is return to the NHS Health Check programme sometime in the autumn, hopefully, with face-to-face consultations with bloods either done in phlebotomy or point of care. So we're hoping to go back to that phase, new normal, back in sometime in autumn. The next question is, how are you working to overcome the risks to the workforce, workplace and patients? So initially it's through delivering remote checks, which takes away the requirement for face-to-face. But this is a time-limited approach because the dates of those blood pressure and cholesterol will run out at some point. So we know that that's a short time period. The use of the digital tool will also help with keeping patients out of practice and lowering their risk. We know a digital health check is not an NHS health check, so we would be pushing through that stage to get back to normal service delivery. So working towards the face-to-face recovery, we'll be working with providers on PPE, and an expectation that costs will rise, and that cost will be passed on to the Commissioner for the increase in PPE and also social distancing measures that may add costs on. But we don't think these costs are insurmountable. And we'll be working with GP and local CCG reps on utilising the new phlebotomy services that are going to be rolled out in Southwark, and those services are also looking not only to take blood pressures but also to take other biometric indicators such as height and weight, and so that therefore some of those trickier health check measurements can be measured within a safe phlebotomy service. And we're also working with GPs about blood testing hubs. The next question was on what funding implications of restarting the service and how are you managing them? So in Southwark, our GP federations have positively declined our offer of supplier relief in Q1. They didn't consider they needed it and didn't see that it would make a big impact on their bottom line. But this is not a familiar representation across South London. I know that other boroughs with block contracts and block targets are having a longer conversations around supplier relief. We're working with our federation providers to scale up in Q3, Q4 to catch up on the annual target, so potentially deliver more checks in those quarters in light of any COVID-19 outbreaks. Particularly Q4 has always been our best performing quarter, and hopefully we'll be coming out of any COVID-19. But we're also looking at potential other ways of delivering the check in terms of taking bloods up to 3 months beyond the actual check itself. One of the biggest resources, I guess, is the time on officers and providers of restart discussions. We have to rewrite the letters with a COVID-19 slant on them, and also renegotiating contracts and finances and so forth. So these are the time considerations. Potential challenges and capacity and capability of workforces. So A lot of GPs in Southwark won't be able to pick up the service straight away. They'll have staff that are vulnerable or shielded due to COVID-19, so there's limitations on who can restart. Some of our practices are hot sites for COVID-19, so their priority would be treating and dealing with that element of the service. So we know that there might be a limit to the number of GPs in the borough that can deliver the service. By using the pre-screen digital tool, we also know that we'll only be sending high-risk people to GP and signposting lower-risk people off to health interventions. So that should help us cope with some of the capacity and making sure that we can control that capacity through the invitation system to those services. The next question was, what are your plans for addressing equity of access and outcomes going forward? So in phase one, we won't be tackling that because we will just be using who's on the record that have bloods. But in phases 2 and 3, so a return to a normal service, we have put up in the council plan now indicators around targeting BME communities due to the growing evidence that Catherine mentioned of the risk of COVID-19 and the impact and the complications thereafter. So we've put forward a target, and so that 50% of all completed health checks this year and beyond will be for BME residents. And we'll achieve that through targeting our invitations, more frequent reminders, working with providers to proactively encourage uptake by BME patients, and also to adapt their services and make it more accessible on weekends and evenings and so forth to try and encourage uptake. So we're aware of that need, and we'll address it going forward. And then on to the opportunities that have arisen out of this crisis. I think that it's fast-tracked a lot of the transition towards digital. I know that the appetite within the public for digital solutions and online services has increased, and we're grasping that. So we know that e-consult in Southwark has gone down well. Telephone consultations is going down well. We're utilising predictive prevention and the data to farm the medical record for people with existing blood pressures and using that to complete the health check. And there might be other opportunities that we haven't looked at before. The requirement's not been there. So I think it's an opportunity to think differently and use data. I definitely think there's a public awareness of public health and the role we play and the work that we do now. And I think we should ride that wave, and also to carry on the messages around exercise, healthy eating, mental health that have been raised during this crisis. And then finally, I think the whole data sharing, GDPR paralysis, there's some kind of emerging evidence in Southwark of weighing up the benefits of sharing data across providers against the issues of GDPR. And I think that might prise open some of those restrictions that we were previously experiencing. So that's a whistle-stop tour of the situation in Southwark. So
great, thank you, Paul. I'm pleased to say I was actually able to hear you, so that was fantastic. Thank you very much for that roundup. You've clearly been busy. On to Linda. Linda, if you could give a kind of overview really of your preparation and planning, that would be great.
Sure. Hello everyone, I'm Linda Seary. I'm a public health specialist in Newcastle, and I'm also a LIMF member, and the portfolio I work in covers NHS interface, which is stop smoking, which is cancer, screening, cervical, all the flu vax stuff, and all the long-term conditions. So it's a busy portfolio. With the NHS health checks, and I just want to share some practical issues that are coming up. Really at this stage, kind of in our path, it's communication with our providers. We have mixed models. We have 12 local authorities, all with different models. Some local authorities have GP Federation providers. They have mixed models. Some have pharmacies delivering health checks. Some have community outreach. So it's not a one size fits all that into a clinical setting. Health checks up here are delivered very proactively and into our communities. So as the first step, we're trying to contact all the providers to discuss their readiness. Are they willing to start? What is their level of thinking? You know, and how do we assess all that as a first step? Because there's lots of practical issues here around equipment. There's protective equipment. There's the social distancing measures. There's all of that. So we have to really communicate with our providers and adapt accordingly and try and plan as to what they feel when they can restart, and when it's possible, and how much support do they need to do that. How are we planning to overcome the risks to the workforce? Well, safety first, COVID secure, and all of that for staff and patients. And I think this is practical. This is all about organising work to reduce exposure. I know that other areas, and I've spoken to Paul extensively around the digital offer, but not everyone does that up here. Whilst health messaging has continued, it isn't necessarily a digital offer as such. So that all needs to be explored. But the practical issues of footfall of patients, organising the flow of information. How do we take bloods? What I mean. So and also there's a thing for me here around staff. Because we have mixed models of providers, then we are looking to provide online infection control training, and we've developed it for care homes. So, and we're about to share that. So, and it's about reassuring people, reassuring staff, and developing confidence and not just competence around delivering the health check again in a safe environment. Is the next one the funding one, Catherine? Yes. The funding, we're all at different stages of preparedness. We had our network meeting yesterday. Out of our 12 local authorities, 4 have agreed to give supplier relief. One actually has continued paying on a block contract for a possible restart in the future, but they've continued payment. We've got 3 where more discussions are taking place, but no particular, massive objections. But we've got about 4 local authorities who are unknown at present. But we know that it's a difficult one, and local authorities must discuss that, in-house. There's an issue that's come up here around, will funding be carried forward next year? Well, probably not. But for me, it's not. I could honestly say up here, it's not about catch up. It's about what is achievable in the next 6 months, and what can we do before the next kind of financial year kicks in. Regarding capacity and capability, because they're mixed models up here, we have had some staff in GP practices, as Paul has said, are shielded or have been shielding or working in phased hours or in GP practices, but some of our community staff have been redeployed or furloughed. So we have to really kind of do refresher training, and again, infection control offered, but all online. So when they're ready, they get as ready as they can be. Everything's up to date, and we can deliver in a prepared way to deliver face-to-face in a safe environment. We're not planning. I've not heard any of my network colleagues mention that they're going to do a digital offer or a phase. We will phase the work in, but we'll assess carefully of what we need to do to achieve that. With regard to what are your plans for addressing equity of access? Actually, this is a huge one for us. This is always big. Really, we want as many people as possible to have a complete health check. and the programme must remain a universal offer. But in that mix, there has to be some focused and intense work around minority, ethnic and vulnerable communities. And we're going to focus on fundamentals. Public health, we're all around, there's high cholesterol, high, blood pressure, risk of diabetes, so obesity, smoking, alcohol, physical activity. We're going to have a high focus on males, just trying to, get them to take up the offer. We do have a residual effect of COVID-19, and that's the mental and emotional stresses on individuals and families. They're not necessarily confident about coming out and meeting people in a public environment. So I think that we need to be really careful, and we need to get our communications right, and we need to do a whole preparatory work in the run-up to any restart, and hopefully we may have restarted tentatively by October. We need to raise awareness and increase perceptions around health conditions and around messages into practices. We know that reaching people in communities is not always possible via GP practices. It's not because they don't do that. It's because the data on ethnicity or some of the data is not always up to date. But we'll keep up the messaging and work with the CCG and primary care, and we'll put information out into the bulletins in their weekly bulletins, and work with individual practices who are ready to kickstart the programme. Opportunities, I think the scale of the challenge is considerable in motivating people to take up the invitation, and we are going to focus on outcomes. We've said for a long time, what has it meant for me to have a health check? So what? And so we'll strengthen pathways. We'll get people into interventions should they take them up, and we're going to focus on the personal, the community, and the population level, and we're going to look at it as a whole and in a targeted way, as well as offering the eligible population. And that's the opportunity it's given. We've always thought we worked like that, but we're going to intensify all that. That's a very quick whistle-stop tour. I think I wrote about 5 pages just of my rabbiting on with a pen last night. So I'm sorry, it was very practical issues, but I just thought I'd give you a flavour.
Lovely, thank you, Linda and Paul, for taking the time to share, your thinking and the considerations that have come up in your areas and across your networks.